So as many of you know, as I introduced myself earlier, my name is Emma Hallam. I am not an expert in pain, but what I am an expert in is helping patients live with pain. Because when patients attend my clinic, 9 times out of 10, pain will be a contributing factor to what their experience is. So that's why I'm here today, to talk to you about pain. So first of all, what is pain? Well, pain is an unpleasant sensory and an emotional experience associated with actual or potential tissue damage. It's a complex collection of sensory, emotional, physiological and certain involuntary responses. It's behavioural reactions provoked by tissue damage, and it's actually part of the body's defence system. So it's a reflex reaction to try and escape painful stimulus, and it's meant to adjust behaviour to avoid the harmful situation in the future. The problem is that pain cannot be seen on a scan, and it cannot be measured by a blood test. So when we talk about pain, we talk about it in 2 aspects. We talk about acute pain and chronic pain. Now, acute pain is what we term as useful pain. This is a pain that usually comes on quite suddenly with a known cause. It's usually sharp in nature, and it usually doesn't last longer than around 6 months. It tends to go away when that cause is no longer there. And it's this warning sign pain. It prevents injury, it tells us to rest, and this is where painkillers usually work. Causes of acute pain tend to be surgery, broken bones, if you hit your finger with a hammer, that kind of thing. And after acute pain goes away, a person usually goes on to live life in their normal way. When we start to talk about chronic pain, this is this relentless pain that can last for many, many months, years. It causes suffering, it's never normally a new sign, and it's a result of this tissue damage and a sensitisation within the pain system. And painkillers often don't work. And this chronic pain is often linked to conditions such as headaches, arthritis, cancer itself, nerve pain, back pain and fibromyalgia. We also know that long-term pain can be more subjective and actually quite difficult to diagnose. It's also, like I said, it's really linked to this psychological link. Chronic pain has a psychosocial component that must be dealt with alongside the clinical picture, before depression becomes part of the holistic management as well. So we think about pain in type, you can break pain down into different types of pain. You get your acute and your chronic, but you also get what the type of pain it is, so whether it's nociceptive and neuropathic, which are the ones that we're going to come to, but already you've alluded today to this radiating pain that might be a cause of something that's happening somewhere else, but you're feeling it in your shoulder or in your hands and feet. So nociceptive pain is this acute pain. It's caused by that actual tissue damage or the inflammation. This pain happens due to the special nerve endings called nociceptors, where they then send pain signals to your central nervous system. So it's very much where you've hit your hand or you've had that direct surgery, and that's where you feel that pain. This type of pain is described as an aching feeling or a throbbing feeling. When we talk about neuropathic pain, this is often when we're talking about the chronic pain, this is caused by a dysfunction in the nervous system or damage to the actual nerve tissue itself. The neuropathic pain is caused by the nerve damage that can occur, and that can be either direct on the nerve or it can be because you've interrupted that nervous signalling system. And this is a type of pain that's often described as shooting, burning, electric shock-like, or indeed numbness, which we've talked about a bit today already. So chronic pain is not a stimulus, but it's an experience. Pain experiences involve thoughts, memories, emotions. Pain is both physical and emotional experience, and it's affected by the mind and body. Now, when we think about types of cancer pain itself, we have the acute pain, so when you were first diagnosed, when it might be the tumour and the cancer that's actually pressing on the nerve. When you've had the surgery or that radiotherapy, so the actual effects that we tell you about that you will experience when you're on your radiotherapy, that's classed as acute pain and acute side effects. The chronic pain is that persists for many years or can develop many months, years later. And that can be due to the actual damage that was done by the surgery or the radiotherapy at the time. Or we also know this progressive nature, certainly in terms of radiotherapy, when we start to get this fibrosis, the stiffening of the tissues, how that affects the area that you've been treated, but also your peripheral neuropathy system as well. We also often can have breakthrough pain, and this is where the medications that you might be on for your chronic pain stop working, or they stop working for a short space of time. And this is where you might need to then either have a different pain medication to act as that breakthrough pain, or take some more of it. So when we think about pain, we think about things as such as we call it the chronic pain cycle. And this is because we know, and we've talked about this already this morning, how anxiety plays a part. Fear of recurrence is a massive thing that patients experience, as you know. And a lot of patients that come to my clinic will often think that, is this cancer pain or the pain that I'm experiencing something to worry about? And that's because we know that the mind and body are actually related. Because the mind and the body works very closely. They're linked and they affect each other. It's not the same as saying that your physical symptoms are all in your head. That's a really important thing to recognise. It means that your thoughts and feelings can affect your body, and physical symptoms can have an effect on what you think, how you feel, and what you do. We also know that persistent and unresolved pain is cyclic as well. And this pain often results in general weakness, fatigue, loss of fitness, tense, tight muscles, reduced flexibility, emotional distress, and reduced quality of life. And patients will talk about this cycle that they go through, that the physical pain stops them doing any exercise, then their body starts to decondition more, then you get more anxiety, you're not sleeping, so you feel that your pain is more increased. And that's the same in a psychological sense as well. That fear and worry that loads that pain then makes the pain worse, so you perceive that your pain is worse and you've got higher pain needs. What patients tell me is that when they come to our clinic is that they're not listened to and they're not heard, and Rob alluded to that this morning. There's some fantastic community and hospital-based pain services, but it's really difficult to access these services. And patients tell me that they don't feel listened to, they don't feel believed about their pain. And we know that clinicians, if they don't recognise that pain, or they can't quite work out why the patient has got that pain, they won't sometimes load an importance onto that. And like I've already mentioned, patients who experience this chronic pain often feel the fear of cancer recurrence is really interwoven with that pain, making their pain needs much higher. So we talk about trying to turn down the pain volume, and when I did my training in the psychological aspects of pain, the psychologist told us a story which I'm going to tell you now. And that was, there was this professor who was out walking in the Australian bush, and he was walking along and he got scratched on his leg. And he thought, oh yeah, I've been scratched by a twig, because that happened to me all the time when I've been out walking. The next minute, he was unconscious on the floor. Excruciating pain, and then he was unconscious on the floor. And that is because he'd actually been bitten by one of these deadly brown snakes. He recovered, he got the antivenom, but he was in a coma for about a couple of days and had problems with mobility for a bit, but everything was okay. So a couple of years later, he's out walking again, and he got scratched on the leg by a stick. Now, his brain told him, gosh, last time that happened to you, you nearly died, you went into a coma. So he was rolling around on the floor in agony, my leg, I've been bit. And it wasn't, it was just a twig. But his brain had told him that that was something he really needed to worry about. So our brain protects us from this pain. So what we need to do is try and work on how can we turn down our pain sensitisation. Sometimes we need to turn it up. You know, if we're going to be worried, if that fire is going to be hot, we need to go, yes, that's going to really, really hurt if I touch that. But other times we need to, and certainly living with chronic pain, whether it be from the late effects of treatment, whether it be from the cancer itself, or other general conditions, because remember, we're all getting older and we're all going to get other comorbidities such as arthritis, and we're all getting a few bad backs and things like that. So actually thinking about pain is important for all of us and how we manage that in the long term. So research has also shown us that other factors such as poor sleep, stress can really sensitise our nervous system. So if we can work on these aspects, we can actually turn down our pain volumes. So we're going to concentrate now on the 4 things really that really impact pain. So when patients come to see me, I really try not to prescribe them pain medication. I also find that patients are living on medication for a long time when they don't actually need to. Patients will come and they'll say, well, I was put on that by the oncologist, and a year later they're still on the morphine which they had for their acute symptoms, so that pain on swallowing they had when they had the radiotherapy. Well, why are you still taking it? Well, because I'll be in pain if I don't. Well, actually, you won't be in pain if you don't, and actually by then you can, with morphine, as we know, it can be quite addictive, so you can't just stop it automatically. So it's really important that we're having these important discussions with patients, and that's what I do a lot in my clinic, is try and unpick it as to why are patients taking that. A lot of the time, absolutely, you need your pain medications, but understanding why you're taking them, what actually they're for, because we know that different pain medications work for different things, and that's not what I'm going to talk to you about today, but some are very much for that nerve pain, some are very much for that acute pain that you might get if you've had surgery or hurt yourself in that acute setting. So we're going to talk about all these things today, but we know the main 4 things are sleep and how we're sleeping. Are we getting good sleep? Are we, that is where we recharge our batteries and a lot of our healing happens. Our mood, so that links into our anxiety. Activity, so obviously physical activity or movement, as we need to call it, and also our energy. So first of all, I want to talk about sleep. The importance of getting a good night's sleep is key, really, for all of us, regardless of what we've got going on a day-to-day basis. But how many people in this room feel that they don't sleep well? No, that's quite good, actually, because normally everybody puts their hands up. And we know that lots of different things affect our sleep. It can be you've had too much caffeine, it can be you've had a bit too much alcohol, and then you pass out and then you wake up a little bit later and you don't get back to sleep. But we also know that pain can significantly impact our sleep. So what I've actually done is, and don't look at them now, you can look at them at the end, I'm going to give you some time to have a look through. I've tried to put lots of information, things that I use in my clinic to give to patients on the tables. Now, there isn't enough for everybody to take one of everything, but you certainly might want to just have a little look through. But one of the things that I didn't print out because it was far too much was the Good Night Sleep Guide. And this is, you can just have a Google it, but it gives you the 7 practical steps to a good night's sleep. So it's not based around patients that have had cancer at all. It's very much about how do you get a better night's rest. But it covers things such as like looking at your bedroom setting, we call it sleep hygiene, but actually some people go, well, I'm in really bad pain. Well, actually it can be your mattress that's causing that pain. So sometimes things that are so simple, we focus so much on the pain that we don't start to think about making them little steps that we might be able to make. But certainly the Good Night Sleep Guide looks at things such as the environment, exercise, relaxation, other therapies, and also hormonal imbalances as well. Then we're going to come on to mindfulness, and we're going to do a little bit of a mindfulness practice at the end, if that's okay with everybody. But mindfulness is really important, and I use it a lot actually now. If you actually get to see one of these specialist pain teams, they will talk to you about mindfulness. We use it in schools now and in education at trying to help with anxiety. But it really is a helpful tool if you can manage to do it. And I think we all need to remember that we don't have to be able to sit there for 25 minutes in a state of Zen, being all mindful. It can be literally a couple of seconds. But mindfulness is an ancient Eastern practice which is really relevant for our lives today. It's a simple concept which means paying attention in a particular way on purpose, in the present moment and in a non-judgmental way. It's simply noticing what we don't normally notice because our heads are too busy, or thinking about what we need to do or what we have done. And it helps to train our attention, often bringing a sense of calm. And one way to do is actually to do some mindfulness breathing, and this is really, really effective and can take a matter of seconds. It's something that I will do before I come and give a presentation, because I know I'm always going to get quite nervous. I'll go and do a quick few mindfulness breaths, and if it's certainly between clinic appointments, because some of the psychological load that we deal with in our clinic can be really quite traumatic for the patient and for myself. So it's something that I will do, just a couple of mindfulness breaths between each patient to reground and reset myself. I do struggle to do mindfulness practice without listening to somebody talking. It's not something I can just sit down and do easily, but the mindfulness breathing I do tend to be able to manage. But the mindfulness breathing, really the effects of this deep breathing are largely psychological, we know that, but it can bring about a physiological response in the body. So just by deep breathing, yes, it's psychological, I'm waiting on the breath, but actually it will have a physical response within your body. It can normalise the heart, and it can also, and respiration rate, and it can also calm you. So hopefully you'll notice that when we do a little bit of mindfulness practice in a little while. The other thing is, and I love this term, motion is lotion. I actually pinched this from one of our patients who's also a nurse. She had cervical cancer, and that's when she does her talk. She always talks about motion is lotion. And I think when we try and get patients to engage in physical activity, it's okay if you've always done physical activity or movement. But if you're somebody who's coming from quite a sedentary place, which we do see, trying to say to them, go on, off you go. do some activity, go and do some walking. They're not going to engage in it. I had one patient once who literally, virtually, and he was only young, 35, didn't even get off this. He sat gaming all day. That's all he did before he was diagnosed. He was a skull-based tumour, and I actually did the 5K couch to 5K. I adapted that to literally 5 minutes of walking, and he had to start with a minute, 5 minutes. We had walking to the bottom of the garden. He had a tick chart to do it. It was just about adapting that to what is him and his needs. But there's lots of information out there, and if you're not very active, it's knowing where can you go and get help and support from with doing some physical activity. There's lots of charities that do it now. So the Move charity has loads of information online about that, but I've just put the Arthritis UK pamphlet on there as well. That's got loads of chair-based exercises in there. So particularly if you are struggling with pain, to start off with, you might struggle to do any kind of even walking, but that's really a good place to start if anybody's interested in that. So yes, remember that. Don't think about physical activity. Think motion is lotion, and you are easing your pain. So this is a website that I use a lot with our patients in clinic, and there's a couple of leaflets about it as well. It's actually livingwellwithpain.co.uk. So it's not just associated to cancer, and I quite like using that sometimes, because especially if you're quite a way out of treatment and your cancer diagnosis, you don't always want everything to be focused around cancer. So to actually have something that's the 10 footsteps to living well with pain, you can work through it, and it also talks a lot around sleeping well with pain there as well. So patients find that really useful resource and tool to use. So where can you find help? So the first thing I'd say is obviously go to a late effects service if you have one, or supportive care, as some of our colleagues are now starting to term these services. But there are lots of local pain services around. Your GP is a really good place to start, particularly if you're years and years out of cancer treatment follow-up, because I know some of you still, some people don't get followed up, do they, even with their salivary gland cancer. But your GP is a really good place to start if you can get in, which I do understand that. But there are community-based pain teams, and there's also really more specific ones, usually more at the hospitals. And they'll use a whole range of things. They'll look at mindfulness, they'll look at exercise again, but they'll also look at medications as well. But it's not just about medications these days. We're using lots of nerve blocks, we use a lot of Botox, certainly with our radiotherapy patients who've got radiation-induced fibrosis. We use ketamine injections, but nothing ever lasts for a long time. But at some point these pain needs will change, and that's why these patients need to be able to have access back into these services. Local rehab teams, we talk a lot now about prehab and rehab, with it certainly around surgery, but we're certainly starting to move it more into the actual supportive cancer care setting as well. So we'll try and get you optimised before you start your treatment, try and get you from a really good baseline that you then might be able to carry on through, and hopefully you'll carry on with good health practice afterwards. Physiotherapy and occupational therapy, again, they're really good places. So I know some patients sometimes will actually pay for these services if you can't access them in the community, but they can really help to manage pain. And then we have the complex cancer late effects rehab service. So this is actually a service that's based in Bath that we use quite a lot. I tend to use it for patients when I feel like I'm getting a bit stuck and they've had lots of pain medication and they're just not really living well with their pain. And this is what this service does. So it's actually a national service, so everybody's got access to it. You just need to get your GP or your healthcare professional to refer you. But what they do is they're a multidisciplinary team, and that's really important. So there's an occupational therapist there, a physiotherapist, a psychologist, a nurse specialist, and a pain consultant. And what they do is they really help you to live well with your pain, help you to turn down the pain volume, and see what is best for you living. They are based in Bath, and it is a 2-week, I'll say inpatient stay, but you're on hospital accommodation. You are free to go. I had 3 patients went on the last one, and they all went to the pub every night. So you're not an inpatient, but it is 2 weeks. Some people will go home at a weekend, but it's Monday to Friday. You just have to be able to get yourself there. Certainly local charities will sometimes help to get you, so we use our hospital charities if patients can't afford to get them there themselves. But once you're there, there's no, your food's provided, everything. There's fridges in the room, so if you are on a modified diet, you can take your supplement drinks and things. But they do a telephone triage first of all, or I think they use Zoom now actually, now with moved up a bit. But so once you're referred, it doesn't mean you have to go. And I do have patients who say, actually, it's not for me, that Emma, or we'll think about it in a bit. And even the team themselves will have a chat sometimes and think, well, I don't think this person's in the right place, or let's just get this thing sorted out first. Obviously, if you're awaiting a scan within the next couple of months, it's probably not the best thing because you're going to be loaded on that with your scan anxiety. But certainly after that, it might be a point to go. But they have a multidisciplinary team clinic discussion. And then you go for your 2-week rehabilitation programme, and then they do a follow-up at 3, 6 and 12 months. And then they discharge you because they give you a toolkit what you can use. So I will use lots of their bits, but I have an hour or so with my patients. They've got 2 weeks, so they really can impact on what we do in clinic, but give you that to help to live well with cancer or cancer pain. So what I want to say is that management of chronic pain often results in needs this MDT approach because it's a biopsychosocial approach. But we need to educate patients about pain. It's not just about you going to the doctor and saying, can you sort my pain out? We need to modify unhelpful beliefs and responses, and we need to help you to understand about the neurophysiological pain, so this brain pain pathway. I've put on there some pain diaries. These are really useful to use before you go to a clinic appointment. Do 7 days worth of monitoring your pain, because when we're in pain, we think we're constantly in pain because it takes over our lives. And actually, like Shane said earlier, when he's out the day in the work, he doesn't even notice his pain, but as soon as he gets home at night and relaxes, it's like that pain's there. So a pain diary really helps you to break down that pain and have a look, but it can be fantastic when you show your clinician about that. So I get all my patients. There's a couple on there, there's ones with smiley faces to have a look at. So here's your slide, Sammy. So ultimately what we need to do is empower patients to adopt an active role in managing their pain, but we must remember that pain is whatever you say it is, and it's however it exists and wherever it exists, and I think that's something as health professionals we need to remember. Okay, so are you happy to do a mindfulness practice with me? It only takes 5 minutes. And then I'll take questions after this. So it's entirely up to you, but you just need to sit quite comfortably, if that's all right. If anybody doesn't want to do it or feels the need to walk out, that's absolutely fine. Okay, so you're going to begin by finding a comfortable seated position, either on a cushion or a chair, and you're on a chair obviously, with your back straight and your feet firmly planted on the ground. Now, I'd like you to close your eyes and bring your attention to your breath. You're going to take a deep breath in and fill your lungs and slowly exhale. And while we do this, we will release any tension or stress that you might be holding on to. What we're going to do is breathe in for 3 through our noses and then breathe out for 4 with our mouths. So if you want to breathe in and out, breathe in and out. And now we'll begin our meditation practice. So as you continue to breathe, feel the sensation of the breath entering and leaving your body. Notice the coolness of the air as you inhale and the warmth as you exhale. Let your breath become your anchor, grounding you in the present moment. Now I want you to shift your attention to your body. Begin by relaxing your forehead and letting go of any tension you may be holding there. Allow your eyebrows to soften and feel the muscles in your face and jaw relax. Letting go of any tightness or clenching in your jaw, and let your tongue rest gently on the roof of your mouth. Next, bring your awareness to your neck and shoulders. Notice if there's any tightness or discomfort, and with each exhale, release that tension, allowing your shoulders to drop away from your ears. Feel a sense of ease and relaxation spreading throughout your upper body. Now bring your attention to your arms and hands. Become aware of any sensations you may feel in these areas. Perhaps you can feel the weight of your hands resting in your lap, or the gentle touch of your fingertips against each other. Allow any tension or tightness to dissolve and feel a sense of lightness in your arms. Now shift your awareness to your chest and abdomen. Notice the gentle rise and fall of your breath as your lungs expand and contract. As you breathe in, imagine that you are breathing in a sense of peace and calm. And as you exhale, let go of any stress or worries that you may be carrying. Feel your body relaxing with each breath, becoming more and more at ease. Bring your attention to your lower back and hips. Notice any sensations or areas of discomfort. With each exhale, imagine that you are releasing any tightness or tenderness, allowing your lower back and hips to soften and relax. Now expand your awareness to your legs and feet. Notice the weight of your legs against the surface beneath you. Feel the sensation of your feet making contact with the ground. Let any tension in your legs or feet melt away, as if it's flowing through the soles of your feet and into the earth. Take a moment now to scan your body and really notice if there are any areas where you may still be holding tension. If you find any, send your breath to those areas, allowing them to soften and relax. As we near the end of this meditation, bring your attention back to your breath, feeling the gentle rhythm of your inhales and exhales. With each breath, feel a sense of calm and tranquility washing over you. Know that you can carry this feeling of peace and relaxation with you as you go about your day. Whenever you feel stressed or overwhelmed, take a moment to reconnect with your breath and find your centre. Now, when you're ready, slowly open your eyes and bring your awareness back to the present moment, taking a moment to express gratitude for this time you've dedicated to your well-being, and try and carry this sense of peace and calm with you as you continue your day.